What about the demographics of the patients that you saw? Were they um, primarily Medicaid? Was it Medicaid and private insurance? Was it primarily private?
Private, private insurance. We had no, we, in the faculty practice, there were no Medicaid patients.
No
It was in
Medicaid.
the clinic, but we supervised the clinic
Oh,
where the residents saw the Medicaid patients. And that was a horrific space where people would line up at 8 o'clock in the morning to be seen anytime between 9 and 12 or 1 o'clock. So, and then they would line up at lunchtime again for any time to be seen. That's just horrible. I checked about 8 years ago. It was still like that. That they would herd people like cattle,
oh,
and
yeah.
that care for clinic patients, people on Medicaid, was not optimal, in my opinion. Yeah.
Yeah, my understanding of this kind of system is that you were an attending physician. So you oversaw the residents who are
Hmm.
doctors in training,
Right.
take care of the Medicaid patients. You,
Right.
as an attending, didn't see Medicaid patients, you had private commercial patients.
Right.
So that's when we start to see disparity in healthcare.
Segregation, and
Right there.
the demographics are about the same. I mean, just a little bit different. There were more people from foreign countries of all over the world who were in the Medicaid clinic. And it's basically the demographics of the eastern part of New York City and western part of Long Island was a wide range. Probably half of the people were white, but the other half were of all various backgrounds.
This is in the
A lot,
Medicaid population that you're speaking.
both. And Medicaid, not in Medicaid, no, it's probably a minority of white people in the Medicaid population, and a majority of immigrants, of all from everywhere in the world. New York City is like that. There's people from all over the world in that part of New York. And so, yeah, and this hospital had a great reputation, so it was drawing from everybody in the Queens area, Queens part of New York City, and the county next to it.
So how do you then segue into Black maternal health?
Oh, well, I was a volunteer with an organization, a grassroots, community-based organization that worked on educating the public about patient safety. So I joined a church where social justice was basically addressing medical error. They had an organization based at this church called Pulse, PULSE, Center for Patient Safety Education and Advocacy. And the founder had lost her son after a tonsillectomy, and the doctors did not check a complete blood count, check for blood loss, even though the child was bleeding from this tonsillectomy, 2-year-old child. So the founder of this patient safety organization lost her son, and she started this organization. I wound up joining the organization because it was based in the church that I joined. And I learned about medical error. I learned how it's important to advocate for oneself, to speak up, to get the care that you deserve, that your loved one deserved.
Mhm.
And that if you don't do that, if you don't watch out for what's going on in the hospital, if you don't ask people to wash their hands before they touch you or your loved one, if you don't check on medication, and if you don't ask, what else could it be, doc? You could experience infection, medication errors, misdiagnosis, all these things. So I started to learn about these things. I started to,
Can I stop you
uh,
for a second?
sure,
You're a
yes,
practicing physician at this point, and
right.
you're saying you weren't aware?
That's right. I was not aware that medical error was a third leading cause of death in the United States until 2006.
Hmm.
And
Think,
yeah,
why do you think that's the case? Why were you
why
unaware?
do doctors not know? Most doctors still don't know that how prevalent medical error is and how often they are misdiagnosing. Doctors are like the emperor with no clothes. That fable where the emperor thinks he's all dressed up in the best finery, and all the people can see that they don't have clothes on. The doctor's wrong way more often than they realize, and they don't listen to the patients. So they have this physician supremacy ideology that makes them the best, the most knowledgeable person in the room every time someone comes to see them. And that makes them blind to a lot of the things that are going on. You don't get taught in medical school, at least it wasn't in the 80s, and I don't think it was in the 90s either, that there's a great potential for medical error, that we must wash our hands. Doctors still don't wash their hands the way they should. So if they really knew, then you would think they would do better. So, right, no, I didn't know, and maybe I'm an outlier, but I learned a lot by being in that organization. We started teaching. We had a interactive program to educate the community about how to speak up and advocate for oneself. And then they sent me to a meeting of the American College of OBGYN. We were the community representative at ACOG's first meeting of as they were establishing the Council on Patient Safety in Women's Healthcare. So I was privy to some of the initial work that was being done to address the maternal health crisis in the United States. And that was in 2013, 2014. So OBGYNs weren't aware how much harm they were doing then either.
So you joined this council, and what did you learn about the maternal morbidity, mortality in this country?
Well, what I learned was that the experts were discovering that Black women were dying at 3 to 4 times the rate of white women. And this was regardless of socioeconomic status, education, insurance, etc. And so a well-to-do Black woman had a higher risk of dying than a high school, a white woman without a high school diploma. So they were scratching their heads. And I thought, wow, they don't know why this is happening. And I had an idea, but I shared this. I called my sister when I got home, and I said, Lisa, they are talking about Black women are dying at higher rates than white women, and they don't know why. And she said, and she's an art historian. She said, Leslie, it's racism. And the next day I went and I said to them, the same people they were having a side conversation. I said, the reason we have this problem is because of racism. And they looked at me like I had 2 heads. There were no Black people at this meeting. There was 19 organizations involved in women's health at this meeting. There were no Black people other than me. And they didn't know I'm Black. But I tell them it's racism, and they didn't understand that. It was like they were clueless. They hadn't read the unequal treatment from the Institute of Medicine from 2003. They hadn't read all the literature about how racism is killing us. You know, they haven't read Harriet Washington and others, W.E.B. Du Bois, for that matter. The book The Souls of Black Folk addressed this issue in 1903.
I'm struck by the point that when you told the story just now, your sister, almost without a second thought, put her finger on it and
without a second thought, right? Without a second thought,
said
no thought,
so.
right?
But your response was, "I wonder what it could be."
Right. I did not jump to that conclusion I did not voice it.
Yeah.
Now, maybe I don't remember what I was thinking, but I remember thinking, isn't that something? My sister is not a doctor, but she knows. Why don't these doctors know? That's why that story sticks with me, because she knew right away. I may have been thinking it, but I didn't voice it to them. I
Mhm.
didn't have the confidence to say that to them until I spoke to my sister, who's a professor, and you know,
And what kind of response
revere
did you
her.
get when you said it's racism?
They looked at me like I was crazy. They just said, they poo-pooed my comments. And who am I? I'm not a maternal fetal medicine specialist. I haven't written any papers. I'm just there as the community representative of a community organization. So I'm not, well known in their circles or anything. So
Mhm.
I'm poking my head into their conversation.
So you were dismissed.
Right. I was dismissed. And it's taken, well, when did ACOG finally make a statement about racism in
Relatively recently.
2001, after George Floyd was murdered, I think.
All right. So, and how does this then turn into your life's work after you retire from practicing OBGYN?
So 2 years later, I retire and I start. I'm out, there's already at this point another Black woman on the board of Pulse, and she and I decide that we have to do something about this. And we decided that we're going to use what we learned at Pulse about patient safety advocacy and how the public can learn to speak up, practice speaking up. We're going to turn it into a program for the Black community to practice how you can speak up, how you can get confidence in speaking up, to know your rights, to understand that you have a right to informed decision making, and et cetera. So that's what we decided to do. And we got started on that in about 2015, 2016. And at that point, we were just telling people, at community programs that there were disparities, that there were inequities, and it actually didn't decide to do something until one of the mothers in a Jack and Jill meeting said, she was an assistant district attorney, and she said, well, you're telling us about these disparities, Dr. Farrington and Nurse James, but we want to know, what is a Black woman to do? What is a woman of color to do to get safe, quality care? So she asked this question, and here we're talking about disparities, and we're saying it's due to racism, but we didn't have an answer for her until we really started to think about it and apply what we were learning at Pulse to a program. So that's how we got started. It was that question that really got us started. I have to reach out to her and let her know what she started. And then after we started our program, I won't go into the details of it. We had focus groups. We worked on that for about 2 years. We had workshops in the community. And even then, I knew not to lead the workshops. And then myself, but we had others. We had young people involved who were leading community members in discussing, what would you say or do if you don't understand what the doctor said? What do you say or do if they are rushing you, or if they're dismissing you? You disagree. How do you disagree? Are you afraid to disagree? What are the different ways that you can disagree? What if you were like Serena Williams? Because around that time, Serena Williams had her first birth and she was dismissed. What do you say or do if you're like Serena Williams? You're in danger. You know you need help and they're not listening. So we go through all of that in our workshops, but we've changed the workshops from workshops for the Black community, and I moved away from Pulse because I knew I couldn't have a program for the Black community and under the auspices of a white organization. And at the same time, an OBGYN attended one of the programs and reached out to me afterwards. And she said, Dr. Farrington, you could use this to reduce Black maternal morbidity and mortality. And I said, well, that's how I got started, but I wanted it to be for the entire community. But then I realized that I could move from Pulse and start something new with her help, because I needed somebody else to be on board with that. And she encouraged me, and her name is Dr. Lori Zephyrin. She's a vice president at the Commonwealth Fund. And it's thanks to her that it kept going and found the other people who were necessary. Obviously, I was not going to be the one to establish a program for Black mothers and their supporters with my appearance and the experience of an obstetrician. It needed to be community members, birth justice activists, and I found them. I don't know, it's all by the grace of God, all by the grace of God. Mama Shafia Monroe, the midwife who used to do home births in Boston, now lives in Portland, Oregon. She's a leader. Nubia Earth Martin, who is the midwife in the movie Aftershock. Darlene Turner, Professor Lynn Roberts from City University of New York, who helped develop the New York City standards for respectful care at birth. All of these people were my mentors. These are the people who created this program. I just said it needs to be something we practice, how to speak up for ourselves. Know that you must bring someone with you, have them on the phone. All of the things that you discussed in your interview with Dr. Leal Liverpool.
Yes.
Yes, and that I highly recommend that podcast. I loved your interaction with her on the topic. And basically, we keep saying the same things. This is the same thing that others have said. But the unique thing about the ACT program is that we are practicing together. The practicing speaking up makes it less difficult. And that was what was highlighted in your interview, how difficult it is to speak up for yourself or for your loved ones.
In the moment.
And what the challenge it is in the moment. And I've experienced it recently. I experienced it last month. This difficulty of advocating. I've experienced it firsthand. And I now I appreciate it even more. But I still say we need to get to build up our skills. The more that we do it, the better we'll get at it. And we use these tips and tricks that are embodied in our curriculum, our ACT curriculum, and they can help make it a lot easier. So that's what we have taken it on the road. We've had it, it's going all across the country. There are even some people in the UK who have taken it up. So I'm very excited about the ACT curriculum and the ACT advocacy toolkit.
So how long has the program been in practice?
Well, our first workshop was 2019. And at that point, I thought that the 100 Black Women, National Coalition of 100 Black Women, would take it up and make it their program, but they didn't. So we established, in 2020, we established the Black Coalition for Safe Motherhood. And we've been an organization for about 4 years. And we now have our training for ACT workshop facilitators is online, self-paced, with a coach also. There's a mentor for those who are becoming facilitators. And it includes how to engage community. And I think that's important. If you want to spread that conversation about how to advocate for yourself, how to go with the armor of God into these healthcare spaces. You need to engage with community in a way that you can reach them. How are you going to reach the people who need to hear it? So that's part of the training to become a facilitator. It's not just how do you facilitate the conversation about what do you say or do in these situations. You're doing it with empathy. You're doing it without judgment. But you also need to know how to engage the community to attend your programs.
So let me be clear, the program is for one to become a facilitator, or is the program for that person, that patient that has to go in and interact with a doctor? Which is,
The workshops is two things. There's workshops in which the community members, the doulas, the husbands, the fathers, the partners come to these workshops for an hour and a half, practice all the tips and tools and come up with your own ideas about what you're going to say or do. How are you going to disagree? You're building confidence. Then there's the people who lead the workshops, the facilitators of the workshops. We needed a training program to get them all over the country, to get those who feel confident about using the tips and tools.
Yes.
They get trained. So there's a training to become a workshop facilitator.
and then there's a training for those that want to learn, how can I better interact with the doctor?
That's the workshops. There's
Okay.
the ACT workshops,
The
and there's
workshop.
the ACT, and then there's a workshop facilitator training.
Okay.
Who's
How long-
gonna lead these workshops? It has to be people in the community.
How long is the training? If I'm so let's take it both ways. Let's say I want to become a workshop facilitator. How long is the training? How do I get the training? Is there a certification process? How
Yes,
does it work?
yes. There's you can sign up on our website for you get 8 hours. If you're a doula or a birth worker, you get 8 hours of continuing education credits. So it's a minimum of 8 hours of time at your computer over a course of a few weeks or a few months. You also will have meetings with at least one meeting with the instructor, at which point you show your skills at facilitating. And so that's when you get your certificate of completion. And there's like 5 parts to it with multiple little videos and quizzes and things in each part. And
And at the completion, I am able to lead a workshop.
right. And so hopefully we have around 60 people who have completed our training over the past 4 years. The past year has been when it's been automated or online. So it's a different training right now, and we're looking at how does that look. A lot of people are recertifying who trained before, because that was like a hands-on kind of training that I was doing with groups on Zoom. So now we're having those people who certified before to recertify through the training, the new training, and because it's more robust now. And it's only $250 for those who want to take it. And like I said, they get 8 hours of continuing education credits approved by Lamaze and International Childbirth Education Association and DONA. That's a doula program.
And can I
And so
charge?
and you can take a workshop. Every month we have workshops for free. There's one tonight. Our organization has a workshop every month. So just so people can see what it's about. Now, in their communities, facilitators may be using it one-on-one with clients, or they may be holding programs. They may be incorporating it into their childbirth education program. There's all kinds of ways that other people are using it, but we have workshops that we offer every month to make sure that it's available for free to whoever wants to come, virtual.
And once I'm a trained facilitator, am I able to then charge for these services? How does that work?
Our licensing agreement with our facilitators is that they would not charge more than $10 per person, because we want the community, we prefer that it would be free, but we understand that people need to pay for their time, or they might be paying for a space. They might be getting food together for the group. So we say that if $5 or $10 charge is okay if they want to do that.
Got you. Can you give an example? If I say to you, I feel like I'm not being listened to. The doctor has 10 minutes to be in and out of the room. I really want to ask a question, but he or she is not giving me the opportunity to do that. Can you give me an example of what you would suggest?
Oh, okay. Well, we have a list of things that we suggest you could say, but it's up to the person to pick out the thing that works for them. But
Gotcha.
one of the things that we suggest is to say, Doc, I really want to be healthy. I really want my baby to be safe. How do you expect me to get this information? If it was you, how would you get this information that we need to be healthy? I have a lot of questions. When would you have time for it? If I was your mother or your daughter or your sister, what advice would you give me in this situation where I have, or I have a list, Doc, when you come in, say, hi, Doc, how are you? I have a list for you. Let me know how this looks. What can we do? What's your time frame like today? Oh, Doc, I know you're short on time. I mean, I'm just giving you all the things that people have said. We listened to the participants in the workshop and we have built a list based on what participants say.
That's interesting. The one thing I did take away from the conversation with Dr. Liverpool is she felt that the onus should not be on the patient. The
Right.
onus should be on the physicians, that we need remediation. We need to learn to address the concerns that the patient have and not depend on the patient to bring it to us. What are your thoughts about that?
Oh, I agree. And I've had lots of people say, well, this shouldn't be on the patient. And doulas are not going to save us. Doulas are getting the same pushback as the patients are getting. And I understand that. But we are right now, we are like totally in the totally wrong space of not saying anything, not having any sense of entitlement. And I think we need that. We need all these things. We need doctors to change, and but they're not going to change for another generation, at least. So ACOG is not pushing the doctors. I would like to see a movement, actually, and this is something I'm about to get into, is getting all the OBGYNs who are birth justice minded to come together. It's probably going to be a group of Black OBGYNs. I'm going to be reaching out to everyone I know, including you, anybody who has any say, with anywhere, whether you're the leader of a maternal mortality review committee, officer at ACOG, whatever the case. I'm just reaching out to everybody. We need a movement amongst doctors to start to use person-centered approach. That's one thing. And then, so doctors do need to change, and we can push the change with a consumer movement. I see ACT as a consumer movement, part of a consumer movement. I see the Earth app as a major force for that. If we have all the Black and brown people who are giving birth writing reviews about through the Earth app about their experiences, and then using the back end data from those Yelp-like reviews, we can use that data to put leverage on the hospitals to do better.
Okay, so
the Earth app, yes.
I need you to explain Earth. It's not EARTH. It's
No.
IRTH app. If you could
Right.
explain that.
Okay.
And
Yeah.
You mentioned ACT.
ACT is my program.
ACTT.
ACTT.
If you could
Okay.
explain those two.
Well, ACT stands for Ask Questions Until You Understand the Answers. The C is claim your space, both physical and mental. That's your bodily autonomy and your dignity and self-determination. So A, ask questions. C, claim your space. Two T's, trust your body and tell your story. And tell your story means trust your body means don't dismiss your symptoms just because they do. And tell your story is make sure your voice is heard, bring an advocate if you need to. Tell your story could be letting the doctor know, gee, doc, that felt so disrespectful. I feel really hurt when you said thus and so.
Even if it's after the fact.
Right,
Meaning
even after the fact.
in the moment, if you said, I didn't say what I want to say, you can write a note, you can send a
Write a note, you can write it down.
Yeah.
Tell your story.
Never too late.
It's never too late to tell your story. And telling your story can be healing. It can be healing and others can learn from it. So tell your story has a lot of meaning. And I would say about asking questions, ask questions until you are satisfied with the answers. You might understand what they say, but you might think, that doesn't make sense. That doesn't make sense what they just said. I'm not satisfied. And so you still need to say why. Why do you want me to be induced? Why do you think I need a C-section? Why? So you in ACT workshops, we go through all the different ways that you can address what you want to say. And it builds confidence, and we know this from our post-workshop surveys. Now, Earth is like birth without the B in bias, and it was started by Kimberly Seals Allers, an author, a journalist, about 7 years ago or 6 years ago. Anyway, it's to capture the experiences of Black and Brown birthing people within the 2 years after they give birth, and the people who support them, their doulas, their partners, any of these people can complete these reviews. And Kimberly Seals Allers realized that she could use that data, de-identified, of course, and take it to the hospitals that are being reviewed and give that information to them so that they can do better. So she's got a whole program around that. And so this is why I'm such a big proponent of it. I guess I was asked to be on her advisory council, and I'm pushing for us to go from 20,000 reviews to 100,000 reviews to 1 million reviews, so that we can start to build that consumer movement. And if we all start speaking up, we're going to be. You can't stop. Speaking up doesn't always save you. Kimberly always says this. Well, a lot of people advocate and they still die, and we've seen that. I'm not going to go through the cases right now, but that's something that it breaks my heart that yes, we could still speak. We can speak up, and we can still not get the care that we deserve. But I'd say that we still need to work on that issue because there's too many people who are too quiet. And there's too many times when they call security on people and put them out. There's too many times when Child Protective Services are called on people. So we need to know how to address this injustice in a way that they don't have anything to say. They can't say anything back to you, depending on, how you say it. Well, doc, what would you have me do? Nurse, I feel like you're not listening. I don't feel safe in this hospital. Can I see the person in charge of patient safety here? That makes them wake up. Things like that, saying you're not safe. I mean, they're really big on patient safety. Quality, is there quality management here? Where's your quality management? And there's a there's a federal civil rights investigation going on because of what happened to Charles Johnson's wife in California. And Charles Johnson is another activist in this space. So we can bring these civil rights things, and so a consumer movement. I'm looking forward to that, and because it's going to take a long time before we get enough midwives, enough birthing centers to give people alternatives. Most people still need to go to the hospital. And so these are all the issues that are weighing on me. And and I'm thinking about and what we can do about them.
I actually feel as though the tide is changing and you mentioned three reasons I feel that way. You're right, in the 50s, 60s, it was a male, OBGYN was a male dominated field. Pregnancy and delivery got medicalized and midwives got pushed out. And now we're seeing more females in OBGYN, more females that are in higher positions. They're not just residents, they're chairs of department and then some, because we need the numbers. We need a critical mass. One person isn't enough. We need a critical mass, and we need them at all levels because there's lots of work to do. And so there is the consumer piece, there is the doctor piece, there's the legislation, there's within ACOG, there's within the AMA, but people are aware, and there are people such as yourself and all the other people that you mentioned that are working to make a change. And I don't think there's been this movement in the past. So that's why I'm optimistic.
No, yeah, but I guess I don't see it happening in my lifetime.
Oh,
But
I'm much more optimistic. I think we're contemporaries, but I
I
remember
yeah.
training. There were no female attendings. There were no female attendings where I trained. There were no Black attendings in this department when I trained. And today, the majority of residents are female. You're seeing females in higher administrative roles. And when you get that critical mass, it's hard to be the only one. And you probably better than anyone can relate to. It's hard to be the only one. And that raised the question that I had after talking with Dr. Liverpool. As a doctor who kind of gets it from both ends, you see what's happening within the system. You have people coming to you because they want protection within the system. How do you position yourself? And so often Black physicians are in the crosshairs, and what do you do? And I think I have an answer, but what do you think? What's the answer that you would give to a Black physician that knows that there's racial health disparities, but they're a resident? They're in this big system and they're a resident. How can they affect change, or what would you suggest?
Well, I'm thinking about the people I've heard from lately. There are residents, fellows who are writing about this issue. I'll send you the one. There's an article on LinkedIn. I just wrote to these, about five of them wrote, they had a whole picture of the landscape of maternal health, the financial landscape, the obstacles. I mean, we're not going to get equity until they increase Medicaid funding. These are some of the obstacles that I see that are preventing improved care, improved quality improvement. So these young people, they can see what's going on. How can they affect change? They've got to band together. That's why I say I'm looking at Dr. Jamila Parrott. She runs Physicians for Reproductive Health. There's a lot of little groups that could come together and have some influence on ACOG. Right. I think we need to form a community. I'm a big believer in the guiding principle of Ubuntu. I am because you are. Yes. And that is how we are going to make change. It's going to come from the Black community, just like Black women have always been the vanguard of justice in the United States, in terms of voting rights, what have you. So I think that's That's the way to go, is to band together. There be strength in numbers, and to put these older people on notice. But there is a big resistance. There is a problem of the money that's involved, the capitalist system that we're working with. So the fact that the legislature in many states and federally is not moving on the issue. The omnibus has been sitting there for 3 years now. So yeah, but I do think, yes, the doctors can change the culture of medicine from a culture of disrespect to a more person-centered approach. And so that does give me hope. But I do think we need to work together more. From the physician side, to change physicians is going to take a lot of sort of pressure from the
I take pressure.
physicians, the younger physicians, yes. And that's why I want to get Kimberly Seals Allers to speak to ACOG, because she's got a lot of things to give doctors to learn from. She has a podcast. She has Birthright podcast with stories, positive stories about birth, to give them examples of how to do better. So I would love to see someone like her speak to a large contingent at ACOG next year. That's another thing that I would like to see happen.
All right. So as one Black woman to another, I thank you for the work that you're doing. It was a pleasure, a true pleasure having this conversation. I'm so happy that we connected, and I hope we stay connected.
I know we will, because I will make sure of it.
All
All
right.
righty.
Take
Thank
care
you.
now.